welcome Dr. Vijay Sankaran, who is the speaker of the day. He's going to talk two topics on spine. He's specialized in spinal surgery. First topic is endoscopic interlaminar lumbar discectomy, followed by TLIF for grade 2 spondylolisthesis. I also welcome moderators Professor K.R. Suresh Babu and Dr. JKPC Parthiban. I thank both of them for kindly accepting this invitation and moderate the session. I think we will start the program. Thank you. Over to you, Vijay.
Yeah, thank you, one and all. Thank you, TANS Scientific Committee. Thank you, Dr. Suresh Jayavalan and Dr. Salamuthu Kumar for giving me this excellent opportunity. I'm sharing my screen now. So my first topic is how I do it, endoscopic interlaminar lumbar discectomy. Can you see my screen now?
Yes.
Yeah, fine. It has been a long journey. Maybe for the past 6 years, we started doing the first endoscopic discectomy just before Corona, but at the time it was transforaminal. And in the past 6 to 9 months, we have been doing only interlaminar because we are very comfortable with interlaminar, but we are trying to do transforaminal as well if an appropriate case arises. As all of us know, why endoscopes are preferred over other instruments in cranial cases. In the same way, in spine also, the main thing is the complications are reduced because we are going transmuscular. So there is very minimal disruption to the surrounding tissues, and so the endoscopic procedures carry lower risk of complications such as infection, bleeding, perineural scarring, and related complications. As I already told you, there are two approaches for spinal endoscopy. One is posterior interlaminar, which we are all aware because we do microscopic lumbar discectomy through the same approach. But here, instead of microscope, we do with endoscope. Still, it is slowly becoming more popular. It is, in fact, more popular amongst the orthopedic surgeons because they use scopes for arthroscopy. Now, the neurosurgeons are also trying to catch up. The other one is lateral transforaminal approach. Today, we are interested in posterior interlaminar approach. We should have a very good endoscope with a wide working channel. Almost all the manufacturing companies come with bevel-ended tubular access cannula, multi-channel variable angled endoscopes, wide-angle lens, high-definition cameras, various sized drills and trifines with various variably angled tip and articulated instruments to reach different angles. So, and again, all the companies come with different types of radiofrequency ablator. In our Revo spine, we have this radiofrequency ablator where, on the left side is a handle. Whenever we press on the right side, the tip, it's a long instrument, the tip bends accordingly, so we can reach the bleeding spot, and it works within water. So that's why we use the radiofrequency ablator, and usually the frequency ranges from 20 to 40. Whenever we use on the dura or the nerve roots, we use 20 megahertz, and in case of on muscular tissue and ligaments, we use higher frequency. These are the slowly over the past 4-5 years, we have accumulated so many endoscopes only for spine. And I just this is exactly, I've just taken the photograph of our endoscopes and the different dimensions of our endoscopes. So it all started with foraminascope, which is on the far right corner. If you see, the foraminascope is quite long. It is almost 20 centimeter long, and its outer diameter is very narrow, and working channel is also quite narrow, and the angle of that is 25 degrees. And the next is, can you see my arrow?
Yes.
So the next one from the right, second one is the interlaminar discoscope. It is again a small instrument. The diameter, outer diameter and the working channel is almost same. And the degree of the endoscopy is also 25 degrees, but it is of shorter length. Whenever it becomes a longer instrument, it is very difficult to hold and your hands start aching quite severely. So we try to be smaller, as much as possible. And in the past 2 to 3 years, the stenoscope has become quite popular. The second one from the left is the interlaminar stenoscope, and now most of our operations is done are done with the stenoscope, interlaminar stenoscope. It is again quite almost same size, with outer diameter is quite big with wider working channel, but the degree of operating endoscope tip is only 20 degrees. So it is quite different from the previous two models. And in addition, these three are from Revo. And in addition, we have MP Surgicals offering a cheaper endoscope, which is only 15 degrees. So it is quite wide, and we use it for endoscopic fusion operations, where we put cages and screws. We use MP Surgicals. So I will, most of the operations are done with interlaminar stenoscope, but in between, we try to use other instruments as we have got them. These are all various instruments which are quite long, and all the instruments you may know because we use similar instruments in microscope, like upcuts, different angled upcuts, 45 degrees, 90 degrees, dissectors, and annular terms, hooks. Here is a hook, which is a retractable hook. This is a trifine. And drills, again, within the endoscope, we can use 2 to 3 millimeter drills. This is a cutting burr, and this is a diamond burr. In between, this is an interesting drill where on one side there is a protecting sleeve. So you can use it on the dura when you have to drill when the dura has already been exposed. You can protect the dura and drill. This is the third drill we have. We use them, and I will show everything in the video. So I'm going to show you 3 cases today, and in endoscopic surgery. All the 3 are done at L4-5 level from the left side for left-sided symptoms. And I chose all the 3 similar because just to avoid confusion, because the endoscopic anatomy and the endoscopic orientation there's a steep learning curve. Even though it is a very simple anatomy in the lumbar spine, when you see through the endoscope, you have to know where the bevel tip is, and then you should know where you are holding the camera, at which angle you are holding the camera. And whenever, without your knowledge, you will just rotate your endoscope. So you should know all those things. So to avoid confusion, I'm starting with L4-5 on the left side symptoms, approaching from the left side. So most of the time, we position the patient like this, where the operating part is the top, so that the venous drainage is going away. And initially, we used to take 3 hours to finish one level. Now we are finishing it within an hour's time. And this is more or less the theater setup. I will show it again. And this is our endoscopic tower. So on the top, you are seeing the endoscopic the monitor. Next is the camera station, and this is the light source. And here is the saline irrigation pump. And the pump varies from 30 psi to 70 psi, and 70 we use for lumbar spine, and for cervical spine we use 30. And this is the radiofrequency ablator I showed you. It varies from 20 to 40 megahertz. And the bottom one is a motor for the drill. So this tower is, I will show you where we keep this tower. And this is always stuck whenever the endoscopic case is going on in the operation theater outside the door. This is the second door inside our operation theater. So this is the surgery when we do from the left side for a lumbar spine or dorsal lumbar spine, left-sided approach. This is the theater setup. The patient is here, and surgeon is standing here on the left side of the patient, and nurse is here, and the instrument trolley, Mayo trolley, and anesthetists are at the top end. C-arm monitor is positioned here, and the C-arm is here. If you see the C-arm, the beam is just on the right of the surgeon, so that I can lean on the on this support whenever my hand aches. And now we are going inside the theater. He is Dr. Deva, who is always helping me whenever I do endoscopic operations. He's giving local anesthesia. At the same time, it is being shot, and we can see L45. You can see the needle here. I don't know whether you can appreciate. You can see the needle here. So we are at L45. Next, we make a stab incision through the skin and through the fascia, and then pause. For us, it is very familiar with artery. So with the artery, we separate once going inside through the transmuscular route, we separate through with the help of an artery at the spinal laminar junction. And then we pass the trocar. It is at L45. And it is landing bang on the lamina. And this is the working channel. It is bevel shaped at the tip, as you can see. And the bevel tip, the longer tip, is always lateral, so that it rests on the facet joint. If once you have opened made a fenestration, if you keep that bevel medial, it may go and injure the dura. So now the endoscope is passed through the working channel, and saline irrigation has been started. So we don't do this much of X-ray. It is only for demonstration we have done. So you can see the endoscope entering at L45 level. So for orienting yourself, this is the endoscopic view. So you can see the longer end of the bevel here, laterally. Can you see? Longer end of the bevel here. So we always rest that on the facet joint to start with. And this is the head end, this is the foot end, this is medial, and this is medial and this is lateral, and this arrow is where the camera head is. So the surgeon is here, standing where the arrow is. So if you see, when the operation goes on, this arrowhead rotates like this, So you have to orient yourself. The patient's head and foot are at the same position, but the surgeon just rotates cranially and caudally just to access different areas, nooks and corners while doing the surgery. Now we are going through the channel, and this is the muscles are, it's a transmuscular route. The muscle fibers are excised, and you can see some fat there. It is with 70 psi irrigation. That's why you're not seeing any bleeding. Even if you see the bleeding, you can cauterize it with this RF instrument. As I told you, it bends wherever you want to cauterize it. And next, once you're, sorry, I will just rewind slightly. At this point, you can actually see the lamina here and facet here covered by some muscle, and this is the interlaminar space, and you've started seeing the ligamentum flavum there. Yeah, this is the lamina, you can see, and this is the facet. Now the drill is used. It's a cutting burr. And it's routine, but how you do with the help of endoscope. Routine, you are making just drilling the lower end of the lamina with this drill first, and once you have reached the depth, now you are seeing the ligamentum flavum on the right side here, and the drilled lamina facet here. Now I'm using the drill with a protector, you can see. So this drill cuts only at the side, and protects the other end. Whatever soft tissue there, here it is protecting the ligamentum flavum. And this is a cutter. This cuts ligamentum flavum. We have got straight cutter, angled cutter. Now the outer layer of ligamentum flavum is cut. That's the inner layer, and you are seeing the epidural space and epidural fat. And this is a 90-degree upcut. The instruments are excellent. That we are using Revo Spine, and the instruments are really good. And you can see it's a familiar territory for you. That's the ascending facet at the deep and descending facet superiorly. And the ligamentum flavum is separated and then excised. Now the nerve root is getting retired. You can see the nerve root here and the dura there. Okay. At the towards the pars intraarticularis, there is some ligamentum flavum which is getting excised. And see, the dura is exposed. We can use the drill, this particular drill, because the other side it is protecting the sleeve is protecting the nerve root and dura. So you can beautifully see the dura and nerve root. So good amount of decompression has been achieved. And now annulotomy is being done. See, now the camera head has come to almost 9 o'clock, 9 o'clock. So that means the surgeon is tilting himself towards the head of the patient. So you have to orient according to that. Now the nerve root sleeve is seeing vertically, but it's not vertical. It is the same, but the surgeon is turning, so the whole image is looking. The disc is getting extracted. This is routine what you know already with microscope, but this is how we do endoscopically. And we have various shaped and various sized dissectors to dissect through the annulus. Medially, the pressure is given as we always do with microscope, and then further disc is extracted. Now I am trying to rotate the stenoscope, which is really difficult, but we can do that with a narrower discoscope. I will show in next case how I use discoscopes to retract the nerve root. Here further extraction of the disc is being done. You can see the nerve root here at around 2 o'clock. The longer side of the bevel itself is retracting, but it is difficult with stenoscope, but it is easier with discoscope. I will explain that in the next case. So once everything is extracted, the annuloplasty is done with the help of RF. And this is the final There is some bleeding at the axilla. You can see the thecal sac and the nerve root. Yeah. So next case, almost similar case, almost similar scan, left side L45. It's the second case. I'm just showing it to explain, how we use various instruments. This is the drill, the cutting burr with a protecting sleeve, and this is a 90 degrees upcut. We have 90-degree upcut, 45-degree upcut, and we use them, alternatively, and that's the ligamentum flavum. Similarly, we use the same cutter, straight cutter, to cut the ligamentum flavum. It's so beautiful when you see so close with the endoscope. This is the advantage of endoscope. And the post-operative pain is so minimal. However, time you have taken in the theater, patient, when he comes out, he comes without any back pain, surgical pain. So ligamentum flavum is separated from underlying epidural fat and then excised. So you see the camera head is at 6 o'clock. That means the head is here and the foot is there. That is, fat facet is getting excised. That medial facetectomy, I mean. The nerve root is retracted. See, this is because of bleeding. If there is bleeding, you get, the medium gets spoiled, so you won't see it clearly. So you need to arrest the bleeding. Whenever you get, that's why you are seeing through the saline. In microscope, you are seeing through the air. Here, you are seeing through the saline. So the nerve root is slowly dissected off, and then the disc is extracted. So that's a thecal sac. That's a root coming there. And we give anterior thrust through the axilla and again approach. So you are seeing the long end of the bevel here. And by giving pressure, the disc automatically comes out. So that's the end of the second operation. Then the third case. So this is the third case. Again, the patient had left side symptoms, and you can see the acute component is on the left side. But you can see there is quite broad-based disc prolapse, and the canal is narrowed on both the sides. So we thought we would approach through the left side, the symptomatic side, and try to remove the disc from inside as much as possible, and try to decompress the canal from the left side, so that we can do bilateral decompression and almost bilateral discectomy from the left side. So for that, the stenoscope is not going to be useful, because stenoscope won't go in, and if you forcibly twist it, it may damage the nerve root or theca. So we have this luxury of having different sized scopes. So what we decided was, this is a stenoscope, and either this or this sleeve, particularly the sleeve, can go within this sleeve. So what we have done is called sleeve in sleeve technique. So the sleeve is already there. So we introduce a longer sleeve through this sleeve, and use a smaller sized endoscope, which is appropriate for this sleeve, through the so that the surgery becomes a lot easier. We can pass the endoscope through the disc. So this is actually our own innovation, sleeve in sleeve technique, because we have quite a few different sized endoscope. The reason why we are using sleeve in sleeve is that just because you have to introduce a thinner scope, if you are taking this sleeve, the saline leaks all over, the pressure is lost, so you will not get the same field. And another thing, when you remove this sleeve and introduce a new sleeve, you have to reach that area, you may injure the nerve inadvertently. So it is better to keep this sleeve and introduce a thinner sleeve with a thinner endoscope. That's what we are doing in this case, so that we can reach both inside the disc as well as across this canal. So we are almost doing the same thing. It's a diamond burr here. So the disc is getting separated. Here it was quite osteophytic. We can use Trifine. We have got a small Trifine. The disc is coming in large pieces in this particular case. See how beautifully it comes out as a large piece. You would have seen it in microscope. Now we want to go inside. Here is where we are using sleeve in sleeve technique. So this is sleeve in sleeve. Once I'm using the sleeve, see how I am rotating it beautifully so that the nerve root is retracted medially. Now this is medial, the nerve root is protected, there is no vital structure there. You can very well, now we are inside the disc, you can see the end plates on both sides. Actually, it's a 25 degrees, as you know. With the discoscope, it is 25 degrees, so you are seeing the posterior annulus here. So we are removing the disc from the other side. And now we are doing over the top. Over the top means we have come out of the disc. This is the thecal sac, and this is decompression of the ligamentum flavum of the opposite side. We have started seeing the nerve root. This is the traversing nerve root on the opposite side. So the size of the incision doesn't matter. It is less than 1 centimeter, but it doesn't matter. It is the transmuscular root and the recovery of the patient. So advantages of endoscopic spine surgeries: the root is transmuscular, epidural perineural scar tissue is prevented, as there is no handling of neural structures or epidural vessels when compared to the microscopic technique. There is minimal bone removal or much of the ligaments, and also much of the ligaments, and PLL is protected. Post-operative recovery is much quicker. But limitations: there is a steep learning curve. Mastering endoscopic anatomy and techniques is important. There is quite a bit of fatigue and cramps of the surgeon's hand, that too in the beginning. The surgical time is long when in the beginning. And as I already told you, nowadays we are finishing in 1 hour for a single level disc. And the long instruments may break, and the instruments are quite costly. And this is our team. And I should thank Dr. Suresh Babu for giving us free hands to do such a costly surgeries, in fact. So now, thank you. The next topic is TLIF, that is Transforaminal Lumbar Interbody Fusion. Any stabilization is to provide a stable, rigid column that encourages bones to fuse. Without fusion, the metal, whatever you put through the pedicles, is going to fatigue and break at some point of time. So we have various types of fusion, like TLIF, PLIF, ALIF, and now WOLIF is quite famous. And posterolateral fusion was famous maybe a decade ago. Now the concept is to get the fusion done across the bodies. Why TLIF? What is TLIF first? It is transforaminal lumbar interbody fusion. Is a form of spine fusion surgery in which the lumbar disc space is fused from posterior approach outside the facet joint through the widened neural foramen. So transforaminal, as the name indicates, it is through the foramen here. And to access the foramen, the facets are removed. So when you remove the facet, the access from lateral is possible, and you are very much away from the neural structures. You are just going to see the exiting nerve root here and the traversing nerve root here, but you are away from the neural structures, and there is no need to retract any neural structure. And as Dr. Suresh Babu was pointing out, it was popularized by the orthopedic surgeons because they wanted to stay away from the neural structures. But it is really a good tech. If you learn it in a correct way, it is a good technique because it gives excellent results. And neural complication like scarring is far less. When doing this surgery, if a patient is symptomatic on one side, just removal of the facet joint on one side is enough. But most of our patients, elderly patients, come with bilateral symptoms, so you end up in doing both the sides. Indications: spondylolisthesis with mechanical back pain and or leg symptoms, previous failed laminectomy with instability, failed lumbar microdiscectomy with micro instability, previously failed fusion surgeries like a posterolateral or any other fusion surgeries, discitis in which for early mobilization, TLIF is done, where we will not put any metal in the disc space. We just scrape out all the muck there and do fusion from the posterolateral side, but we can remove the facet to access the disc. We do not do TLIF for degenerative lumbar disc disease without instability. We encourage the patient to do core muscle exercise, reduce weight after doing lumbar microdiscectomy. Doing TLIF, we strongly believe it is not indicated for mechanical back pain without instability. Excuse me. So why TLIF instead of posterolateral fusion? In the biomechanics of spine, Wolff's law comes into play. It says bone grows and remodels in response to the forces that are placed upon it. So whenever we fuse across the bones, the bodies, the fusion is a lot better rather than if the slip is here and we fuse from behind. So instead of posterolateral fusion, if you do interbody fusion, the results are excellent. And because we are retracting less of nervous tissue, we prefer TLIF over PLIF. So in PLIF, the access is like this. You are going to preserve the facet on both sides. You are going to retract the neural structures and go in and place the bone and cage. But in TLIF, as you see here, you are going to remove the facet, do not touch the neural elements at all, go from forlateral and fuse the bones. As you see in the graphic, as Dr. Parthiban was also pointing out, in degeneration, the disc collapses. When the disc collapses, the facet joints override, and it narrows the foramen above. So it is very important to decompress the exiting nerve root as well while you are decompressing the traversing nerve root. And that is very much possible when you remove this and this facet and enlarging the facet, the foramen. So that's why TLIF has got, in all, theoretically, TLIF is a very good procedure to decompress the foramen and release the exiting and traversing nerve root and fuse without disturbing the thecal sac or the nerve roots. The surgical steps: we put the pedicle screws, and then while putting the pedicle screw, before putting the pedicle screw itself, we remove the facet so that the anatomy becomes clearer. I will explain in the video. So once the pedicle screws are done, we put we place the rod on one side and distract at the same time, pull the superior body backwards. You have to do both at the same time. You have to distract on one side, at the same time pull the superior body posteriorly so that it comes into place, but it brings the vertebra back maybe to 30-40%, and the rest of the pulling is done when you do discectomy and distract anteriorly. So when you do the anterior distraction, the rest of the body also comes back. So that is how it is done. I will show in the video. And once distraction is done, we place some bone chips and cage and do compression and fix. So this is how TLIF is done. And technical aspects, we preserve the midline tension band. It is not preserving the midline at that one level. If you see the supraspinous ligament and interspinous ligaments, they form a band from occiput to sacrum. So it's a continuous band. If you in PLIF, you are going to disturb that band. So that means even though you fuse at that level, the band is disturbed, and so the patient may have back pain. So in TLIF, there is no need to disturb the midline. So you are just preserving the midline tension band. The spine is preserved. Mid part of the lamina is preserved. The interspinous and supraspinous ligaments are preserved. And next step is identifying the facet which you are going to break. So you need, before touching the capsule, you should identify the level which you are going to disturb. And you are allowed to damage only the lower facets. How many level of TLIFs you do, you are allowed to damage only the lower facet joints, not the uppermost facet where you are going to put the screw. Because if you damage the upper facet, that will disturb the adjacent level. So patient will get the adjacent level disease soon. And then that's why I'm saying do not damage or open the superior joint. In sacral screws, we prefer tricorticate purchase, but sometimes we end up in doing bicortical as well. So the sacrum is a weak bone. It's mostly a cancellous bone. So if you get a bicortical or tricortical purchase, it is always preferred. To get tricortical purchase, you have to target the promontory of the sacrum. We prefer to use 6.5 screws, and particularly for sacrum, but 5.5 millimeter screws are also okay. And as I already told you, while reducing, it is diagonal distraction and reduction of the superior vertebra over the inferior vertebra. We use titanium cage for interbody fusion, and nowadays we use PEEK cage as well with a lot of bone chips. And finally, you give a interbody compression before fixing the rods. Here is an example. We have got this 33-year-old gentleman with this scan with severe back pain and neurogenic claudication. Obviously, it is lytic type of, you can see the pars defect. It's a lytic type of spondylolisthesis. And to reduce the lysis, the listhesis, it starts from positioning. See here, this gentleman is positioned in so much of extension. You can see the extension happening at the leg level, at the thigh level. We have put 3 pillows here and 2 pillows here to extend, and so that the spine is in a position of reduction throughout surgery. And so the surgery, we start the surgery here. It's not a big incision for one level. The midline is preserved. We make sure that we are dealing with the correct level by moving the vertebra. And that is the facet which needs to be, we should have done an X-ray here. We did X-ray, but I didn't show that to know that we are at the right level. The lower facet, this is lower, that is superior. The lower facet is being broken off. I will show that again, okay? So we move and identify the level. And with the X-ray also, we identify that level. And once that is done, we open that facet. We excise the capsule and open the facet. So this is the descending facet, and the ascending facet is there. And the descending facet is broken. And this bone is used for fusion. You can see the midline is completely preserved. So now, I will pause the video here. Now I got the anatomy very clearly. This is the ascending facet, and that's the ala of the sacrum. So that's the entry point. With the facet in, the entry point, it's slightly difficult to identify the entry point. But once you have done the facetectomy, your facet joint is open. So you can see the superior facet of the inferior vertebra and also the transverse pulses and identify the entry point. So that's how the entry point is defined here. So this is to break the cortical bone, and we do an X-ray to identify the trajectory. So we are aiming at the ala of this, the promontory of the sacrum. We are trying to aim at the promontory so that you are going to get a tricorticate purchase. This is the one cortex of the end plate. This is the anterior cortex, and you have already got a third cortex. This is called tricorticate purchase. We aim that in sacral screws because sacrum is a weak bone. This instrument is called STEFI. So this instrument is we use for sacral screws. It is very good in getting a bicortical or tricortical purchase because you can define the depth here. If I want 35 millimeter, I can put 35 millimeter, and I can use force and use a mallet to hit. So it will not cross 35 millimeter. So it is a very good instrument called STEFI, and that is used for getting a tricorticate purchase. Now the assistant is holding, and it is malleted. Once you are sure that you have got the tricorticate or bicorticate, yeah. Now you saw the giveaway. That is where the anterior cortex is pierced. See, you can see the giveaway. Yeah, that is where the anterior cortex is pierced, and we measure the length. It is usually 35 to 40 millimeter, and directly we can use the. In some companies, we can use the screw directly. And now we are at the superior facet. Here you are not allowed to damage the capsule. So here you have to identify the transverse process and then move medially so that you do not disturb the capsule of the facet joint. If you disturb this capsule, the patient will definitely get the adjacent level disease. So the transverse process and the lower end of the ascending facet identified, and the mammillary process is removed. Here there is no need for a bicortical purchase because the bone is strong usually. This is L5. This is Lenki, which is used to, it's a pedicle seeker. So we use it to pierce through the pedicle. And this probe, we use the rest of, once we have gone through the pedicle, the rest is done through this probe. So once the threading is done, sorry. So 45. The pedicle is felt so that there is no breach. Once we have confirmed that there is no breach, the screw is placed. It's a 45 millimeter screw, 6.5 into 45. So this is, you can see the listhesis here. This screw is anteriorly placed and this screw is slightly posteriorly placed. So our aim is to reduce it. So basically, while for that, you need to put the screws on the other side as well, then distract and reduce. The other side screws are also placed. Now we are going to distract on the left side. The lower screw is tightened. And you see the rod is so posterior to the screw. And this persuader instrument is the one which is going to pull the superior vertebra. You have to distract and at the same time pull the superior vertebra. So the assistant is distracting and the surgeon is pulling. While pulling is distracting, while doing both, you get good reduction of the vertebra. Once the adequate reduction is done, you put the inner screw so that there is distraction and reduction, and you place the inner screw. Now you have got all the 4 screws in. Now the TLIF is going to be done on the right side. The interbody fusion is going to be done on the right side. The facet is removed. We use microscope at this stage. I'm sorry for not showing the microscopic surgery here. So that is the traversing route, which is decompressed. And you are actually, this is the exiting route. So in between, this is the disc. The disc is excised. Now, once the disc is excised, you use this instrument. This is called sizer. We start from 8 millimeters. Slowly, you distract the disc. Slowly, size after size, you distract the disc. So when you distract the disc anteriorly, it reduces further. Now end plate is prepared by removing all the cartilaginous portion. It should be, these are various curettes. It is called box curette, various curette to prepare the end plate. If you don't prepare the end plate properly, the patient will not have good fusion. You should use various curettes, ring curette, box curette to prepare the end plate. You should not have any cartilage there. This is the box curette. There are 2 box curettes, one for the superior and the next one for the inferior end plate. And this is the final sizer to know which is the correct size gauge. And final wash is given in the end plate. We usually reach up to the anterior annulus. You can feel the anterior annulus. This funnel is used to place the bone. The funnel tip is placed within the disc. It is usually a 9 millimeter funnel, so that if you have already used a sizer of 10 millimeter, you know that you can pass this 9 millimeter funnel. Once that is done, the cage is placed, and the TLIF cages can be rotated inside with this instrument to align in the transverse position. And once that is done, a rod is placed on the same side. We release this screw and compress first on the side where the TLIF is done, and then compress on the other side. See, the compression is first done this side where the cage is placed, and then done on the other side. Bilateral microscopic decompression of the exiting and traversing nerve roots are done. And this is the post-operative X-ray. You see how much reduction has happened here, and the foramen is wide open, and the cage is in place, and bone chips are here. So very good fusion has happened. And actually, you should see the results. I have a patient who is coming for I think 4th or 5th year follow-up after a grade 3 spondylolisthesis reduction. Her back pain and neurogenic claudication, which she has been having for so many years, has disappeared, and they're so happy. So if you achieve this much of reduction in a lytic type of spondylolisthesis, they're so happy. And this is the pre-op and post-op. And thank you.
The number of participants also is very good discussion by our moderators, Dr. Parthiban, Dr. Thank you, Parthiban sir. Thank you, Suresh sir. Thank you, Vijay, for a very, very, very excellent lecture.
Thank you. Thank you.
Especially endoscope is completely new to me. It was a very, very good lecture. Thank you, everyone. Thank you.
Thank you all. Thank you all.